This morning I want to talk to you about a piece of work that we've carried out in Sheffield, and the idea of this work is really to look at the different ways that people get to be in a PICU and the impact that ethnicity has on that journey. But before I tell you about this, I want to explain the background, both the general national background and a little bit about the local background. Now, during this presentation, I'm going to be using some very strong language, and I hope that doesn't offend anybody. But I think it's important in order to be able to fully understand what I need to explain to you. So, there are many reasons why ethnicity is important to those of us working in the mental health field. Different ethnic groups have different frequencies of presentation of common disorders. They may have different modes of presentation. There are different ethnic sensitivities and requirements, and sometimes there are ethnically specific patterns of drug misuse and ethnically specific psychiatric syndromes. But perhaps some of the most important and certainly some of the most disturbing implications for mental health came out of this independent inquiry into the death of David Birkett, also known as Rocky Bennett. David Birkett was 38 when he died in 1998. And he'd been suffering from schizophrenia since the age of 20. He was an inpatient at Drayton Ward, which was the ward at the Norvic Clinic, a medium secure unit in Norwich. And on the day that he died, in fact, astonishingly, events started at 10 p.m. and I'm going to take you through what happened. So there was one phone only on Drayton Ward, and another patient, DW, had just started to use it. David Birkett went up to DW and said, "How long are you going to be on that phone?" A few minutes later, he came back and he said, "Give me that fucking phone." He pulled the phone from DW. DW pulled the phone back. David Birkett hit him and drew blood. While DW went and got some medical treatment, but as soon as he had finished with his medical treatment, he went to David Birkett's room and he stood outside and he said, "You black bastard." He said, "You niggers are all the same." David Birkett came out and DW hit him on the chin hard. A fight ensued. The staff broke up the fight, but David Birkett was saying, "I'm going to get him." Obviously, somehow these two needed to be separated. The staff decided that out of the two of them, David Birkett was the one whose mental state was actually more fragile. And so they decided to move him to Thorpe Ward, which was known as an admission ward, but in effect was used as the unit's PICU. So people could be transferred there if their condition deteriorated for a period of time and then transferred back. So David Bennett wasn't very happy about this, and he really was saying, well, why is it me and not him? The staff managed to get him across there, though. They persuaded him to go. But as soon as he got there, he said, well, what about DW? Is he going over as well? They said, the member of staff said, sorry, no, that's not the plan. That's as far as she got, because he then launched into a savage attack on her, and it was pretty savage. She was off work. I mean, I don't know how long, but she was still off work by the time of the inquiry, which occurred 5 years later. This, in the context of this attack and trying to manage the situation, the staff engaged in a prolonged restraint on the floor with David Bennett, and during that restraint, he died. And that is why we ended up with the inquiry. For the inquiry, racism was at the forefront of their minds. Now, obviously, there was overt racist language and taunts used during the time of the events leading up to his death. But in fact, what was more concerning to the inquiry were concerns about institutional racism. Now, institutional racism had been sort of set out by William McPherson, in fact, shortly after David Bennett's death in 1999. And the definition that the Stephen Lawrence inquiry came up with says that institutional racism is the collective failure of an organisation to provide an appropriate and professional service to people because of their colour, culture, or ethnic origin. So think about that definition. The collective failure of an organisation to provide an appropriate and professional service. So they asked themselves, and they asked their expert witnesses, they were, you know, is there racism? Is there institutional racism according to this definition in the NHS? And they asked several expert witnesses. One after another, they all said, yes, 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 there is. So what were these concerns that the inquiry was concerned about? Going from the narrow to the specific, to the general, sorry. Firstly, in the events leading up to David Bennett's death, it was said, you know, they reasoned that this was not the first piece of racist abuse that David Bennett would have suffered, and in fact, you know, people from black and ethnic minorities are likely to face racism on multiple occasions during their time in the NHS. And the inquiry reasoned that this process sensitises people to the racism. Because the racist abuse had not been dealt with appropriately at the time, they reasoned that it was natural that David Bennett would be left feeling that he was the victim, even though he was the one who threw the first punch, and that because no action had been seen to be taken by the clinical team, that they could understand why he felt perhaps that a wish that he had a wish to retaliate. In a more broad sense, they felt that his cultural and spiritual needs had not been considered carefully enough, and that this could have in fact worsened his clinical problems. This was said to have occurred against a backdrop of a situation where there weren't enough staff from the ethnic minorities. There wasn't a proportionate representation from the ethnic minorities in the staff, according to the composition of the patients. And the white staff who were there were coming from an area with a very low population of black and ethnic minorities, and therefore they might have a less good understanding of the needs of those groups. These issues are important to all of mental health, but they're particularly important, I would say, to us concerned in low secure and intensive care, because the issues all came to a head in the context of David Bennett's move to Thorpe Ward. Although the inquiry didn't put it in these terms, it's likely that the patients in Thorpe Ward were sort of had more black and ethnic minorities than the population from which they were drawn. The inquiry just said, well, of course, they're not just coming from Norwich, but I think I don't think Cambridge is that has a very high population of black and ethnic minorities, so probably they were overrepresented in this population. So it raises the question of whether people from black and ethnic minorities are overrepresented in PICUs and low secure services and medium secure services more generally, and whether there is some problem with the way that we're assessing people for admission into these services, which is causing their overrepresentation. Our own Dr. Pereira gave evidence and confirmed, yes, indeed, there is evidence that the black and ethnic minorities are overrepresented. Why? Now, the inquiry and research generally comes up with two possible explanations, which are not mutually exclusive. One is what you might call big, black and dangerous. So black patients are perceived as more dangerous, and therefore they are more likely to be admitted into these units which are there to deal with aggressive behaviours. The other explanation is that actually they are getting a very poor deal in some way or the other from the mental health services, and because of that they're not being treated effectively. Then they are getting worse instead of better, perhaps, and they are ending up at the severe end of the care spectrum. One of the, you'll be probably familiar with the Count Me In census that occurs every year, and I think one of the reasons it occurs, not entirely, but in part, is a response to the David Bennett inquiry, and they are very keen on looking at the representation of ethnic minorities. It's one of the main things that is in their report. Interestingly, they don't tend to dwell very much on intensive care populations, and in fact it's quite difficult to find this information because you have to go back to the raw spreadsheets that they provide, and you have to lump together several different categories in order to come up with a sort of high care, because some of them are called PICUs, but actually not very many, and we know that there are more PICUs than the number of PICUs that appear in the count median census. Some of them are called extra care areas. And this is the latest data from 2009 census. And you can see that there is a higher percentage of black and ethnic minorities in the high care setting compared to the assessment and treatment. Now, this is not a very large difference, in fact, but it is highly statistically significant. In Sheffield, this work originally came out of an audit which was done around 2002 and showed that our PICU, black and ethnic minorities, were overrepresented in comparison to the general adult wards. And this is a full census of Sheffield admissions for the year 2007-8, and it shows the same pattern. So you can clearly see that whereas in the population of Sheffield in 2001 was under 10% of black and ethnic minorities, there was over 20% in the inpatient population and over 40% in our intensive care service, which is called ITS. So how can we start to think about this? If we think about the population as a sort of a pyramid, then out of the general population, there will be some people who are seeing their GP for reasons of helping them with mental health problems. Of those, some will have been referred on to secondary mental health services. And some of these will be in an inpatient setting. And finally, some of the inpatients will be in psychiatric intensive care. Now, what happens when we start to look at ethnicity? This is a very stylized diagram. I have to stress this is not meant to be proportionate or representative in any way, but what I want it to illustrate is that as you go up the pyramid of severity, the proportion of people of black and ethnic minorities increases. Another way of thinking about this is to say, supposing we think about the severity, the level of care along one axis, and we look at the level of illness and risk, which I'm conflating here, along the other axis. At every stage, you have interfaces, you have areas where people can go backwards and forwards. And supposing we say that this blue line is the white British population. So as you expect, as we look at the more intensive inpatient settings, the level of illness and risk that we see in those settings is higher. Now, what I'm trying to show here is that if we had this kind of diagram, we could try and start to understand what was going wrong in the care of people from ethnic minorities. So this is one possible hypothetical scenario. So supposing people from ethnic minorities are presenting to their GP late and therefore more severely ill. And because they're presenting to their GP late, everything else, they're more ill at every stage of the process, and that is why they end up being overrepresented in PICU. Or maybe they're presenting to their GP on time, but they are being diagnosed late. And in fact, there is some evidence that both of those things are true, that they are both less likely to go to their GP because their experience of a GP consultation is less satisfactory, but also that GPs are poorer at diagnosing mental illness in black and ethnic minorities. This is another scenario. In this scenario, this is the sort of the big black and dangerous scenario. So at each stage, people are being moved on to a higher level of care, although their illness doesn't actually warrant it because of the racial stereotyping. And in this scenario, it's happening only at the stage of PICU. So what I'm saying is, if we had this kind of diagram, we could try and understand what was going on. We didn't have the time to. What that would require would be to look at everyone at every stage of the process, and we didn't have the time to do that. What we did was we looked at the notes of 100 consecutive PICU episodes between December 2002 and June 2006. It was a retrospective case note study, and the coding sheet was about 10 pages long, so we extracted a lot of detail on those 100. In fact, I should stress, they're 100 episodes, they're not 100 patients. So we made a decision that actually if a patient came 3 times during the study period, they would be counted 3 times. And what we recorded were the indices of severity, risk, treatment and engagement, and we did that for all of these stages on the PICU, before they got to the PICU in the open ward, on the admission to hospital and in the community. I should say on ITS in our system, only minority of patients are admitted direct from the community. We ask the general wards to try and manage the patients in the first instance, unless it's very clear that the patient would not be manageable. So what did we find? In general terms, we had more males than females, as you'd expect. Moving on to the ethnicity. Now, the experts will say, rightly, that it's not correct to lump all people from ethnic minorities and black together. However, I'm going to do that, and the rationale is that actually, if you look at this, you're going to, in order to analyse it statistically, you're going to have to do some lumping. It's obvious that, again, we've got about 40% black and ethnic minorities here, so they're clearly overrepresented. If they're overrepresented, then I think it's legitimate to lump them together and study them together. So I'm going to start off by showing you some of the indicators of risk and severity once these people were on our ward. This is a scale that we've done. The raters went through the notes and looked for evidence to help them put the person in the correct category. And so we just invented these scales, and you can see how the index of risk goes up through shouting, threats, violence without significant injury. Severe violence is either complete recklessness to the consequences of violence or an intent to cause serious injury. And the statistical analysis of this shows that there is no difference between the groups. We're looking at the frequency of violent incidents, and we classified these into less than weekly, more than weekly, and more than daily. And again, there's no statistically significant difference between the groups. We looked at what nursing measures were used. Routine observations 1-to-1, 2-to-1 and greater than 2-to-1. No difference. This is interesting. We wanted to look to try and work out what the patient's experience was of victimisation. And we classified this into objective victimisation, where we could that it had been clearly documented that the patient was being victimised in some way or another, and subjective victimisation, where the patient felt they were being victimised, but there was no objective evidence. And we further subclassified that into where it seemed to suggest that the victimisation was delusional and where the victimisation wasn't. No significant difference between the groups. And finally, for this section, the use of seclusion on ITS, less than weekly, more than weekly, and none at all. No significant difference. Now, I looked at the data set last night, and there were well over 150 variables. So for humanitarian reasons, I'm not going to take you through the whole data set, but I'm going to summarise it and say, actually, for almost all of the indices you look at, whether you're looking at indices on ITS, whether you're looking at indices on the open ward, or in the community prior to admission, you cannot get a cigarette paper between the groups in terms of their risk. But just to think about that for a while, because it is a little bit difficult to get your head around. What we're saying here is that the people who from black and ethnic minorities who ended up in our PICU had the same profile in the community as the white British people who ended up in our PICU. Okay? So what we're really saying is that people with that profile were not only very much overrepresented in the PICU, but what evidence we've got suggests that people with that profile may be overrepresented in the community as well. Now I'm going to come on to the few variables that did show a significant difference between the groups, and discuss the implications, and then finish. Okay, there's an age difference. This is actually what we'd expect because the age is younger. The black and ethnic minority general population is younger than the white British population. So that just, I suppose, shows us what we might expect. This is interesting. There were no patients from black and ethnic minorities during that period where we found that there was a problem of significant non-compliance with our treatment. Astonishing. But bear in mind that these are a few variables out of a lot of variables. It is possible that we might find differences just by chance, just by the fact that we've looked at so many different things. But there does seem to be a bit of a story building up here. Again, there's a difference if we look a bit further back, because we looked at the reason for referral, and people from black and ethnic minorities were less likely to have been referred with non-compliance given as a reason for us to consider them. Then we also looked at the antipsychotic dose that had been given to these people, and we looked at it in we looked at it 3 times actually, soon after admission, 14 days before referral to us, and 2 days before referral to us. Now, there's no actual difference between the groups if you look at if you just do a straight comparison at 14 days and at 2 days before referral to us. But if you look at the change in their medication during this time, there is a significant difference. And what we find is this is what's called a box chart. So the heavy line, which I think is at the bottom on these, is the middle of the range, and the edge, the whiskers are where most of the cases are grouped, and these blobs are outliers. So what we see here is that most people from black and ethnic minorities, the medication didn't change very much in the 2 weeks up to referral. And in a couple of cases, it stopped completely. Whereas for white British, everyone was either stayed the same or increased their dose in the fortnight leading up to referral to us. So if you put that together with the issues of non-compliance or lack of non-compliance, it makes you wonder. So coming to the conclusions, obviously we replicated the audit and other findings that there's overrepresentation of black and ethnic minority patients in our PICU. Less likely to be non-compliant and more likely to have had a medication decrease. So maybe maybe these people had an illness which was seen to be more social than psychiatric. I don't know. Why should their medication be less likely to be increased if people think that they're heading towards a referral to intensive care? But apart from these differences, I've called this a stick of rock, so you can slice these groups at any stage you like along the pathway, and they look the same as each other and the same overall pattern. So we can think of the severity curve maybe being shifted to the right for people from black and ethnic minorities. Perhaps this shows that there are adverse factors at every stage of the pathway, that there are adverse factors in the community and that those are perpetuated in the outpatients and inpatient services. Importantly, we've, I think, shown to my satisfaction that we don't have a different threshold for admitting black and ethnic minority patients to our service, and that's good news, I think, for us. And also that there was no difference in the perceived victimisation. I think that's good news as well. So, how could we take this forward? Well, with a retrospective case note study, you've always got the problem that you're limited by what people have decided to record. Now, it's possible that there was some bias and the people were more likely to record something different for people from ethnic minorities. If we'd seen lots of differences, that would have been a bigger concern. Because we've seen the same thing, it's maybe not so much of an issue, but from a methodological point of view, it would be a good idea to have a prospective study. More importantly, I think it would be good to actually look at the people who didn't come to us as well to get a more in-depth understanding of what's going on. And this might help us to characterise the risk factors which are predictive of need for PICU care, and look to see whether those risk factors are overrepresented in black and ethnic minority patients, which might help us to understand why these groups are overrepresented in the PICU. finally, I think the data raises some interesting issues about the days leading up to referral. Why on earth would some patients have their medication decreased? It might be useful to go back into the data set and actually pull out the notes of the patients who've had their medication reduced and see whether we can see any themes emerging that might help us to understand why it was more common in the black and ethnic minority patients. And finally, I think it would be useful to compare the characteristics of the compliant and non-compliant patients to try and understand why patients who are compliant are overrepresented in the black and ethnic minority populations who need admission to intensive care. So that's it. Thank you.